Welcome back to the Deep Dive. Today, we are focusing on an activity that you are almost certainly doing right now, unconsciously, probably about 12 to 20 times a minute. You are negotiating with the atmosphere.
That's a very high stakes way to describe breathing.
What it is, isn't it? I mean, we tend to think of the lungs as these, passive balloons just sitting in our chest.
Just bellows.
Right, just bellows that move air in and out. But when you really dig into the physiology, the lung is a bit of a biological paradox. It's really the only internal organ that is constantly physically intimate with the outside world.
It's an interface. That is absolutely the best way to think about it. It's not a container.
An interface, I like that.
Yeah. I mean, if you were to take the alveolar surface area of your lungs, all those millions of tiny sacs where the oxygen actually meets the blood, and you unfolded it, laid it out flat, you'd be looking at a surface area roughly the size of a tennis court. And that entire surface has to be incredibly, almost impossibly thin. It has to be thin enough for single molecules of gas to just slip through into the blood, but at the same time, it has to be robust enough to handle everything that comes in with that air.
So viruses, bacteria?
Viruses, bacteria, diesel fumes, pollen, cigarette smoke, you name it.
It's an impossible job description.
Oh.
Please stay wide open to everything, but also please protect me from everything.
Exactly. And that fundamental tension, that balance between the absolute necessity of airflow and the biological imperative of defense, that's where all the pathology happens.
That's the tightrope.
Yeah, it is. When that defense system gets a little too aggressive, a little too twitchy, you get asthma. When the damage from the outside world starts to overwhelm the repair mechanisms, you get COPD.
And that is exactly where we are going today. We are doing a deep dive into pulmonary pharmacology.
We're opening up the chemical toolbox we use to try and fix that broken interface.
And to do this, we have pulled two of the heavy hitters from the medical canon. We've got CATSM, Chapter 20, which gives us that essential clinical framework. The definitions, the drug classes, the what and the when.
And we have paired it with Goodman and Gilman, Chapter 40. And, if CATSM is the map of the city, then Goodman and Gilman is the engineering schematic for the power plant. It takes us down into the molecular engine room to really explain the signaling pathways, the G proteins, the kinases, the gene regulation, the how and the why.
Right. So before we jump in, let's just set the ground rules. This is a synthesis. We're building a conceptual framework here to help you understand the material.
It's not a replacement.
Definitely not a substitute for reading the primary texts. We really want to prep your brain so that when you do open Chapter 40 and see those, incredibly complex signaling diagrams, you'll actually enjoy them.
Enjoy might be a strong word for some.
Fair enough.
But you will certainly understand them better. Reading is and always will be essential.
So what's our roadmap for today? We have a lot of ground to cover to do these texts justice. What are the key takeaways we want you, the listener, to have really locked in by the end of this hour?
I think we can break it down into 5 main destinations.
Okay.
First, we have to define the battlefield. We absolutely need to distinguish between asthma and COPD, not just by their symptoms, wheezing versus coughing, but as two fundamentally different cellular failures.
That's different diseases, not just different flavors of the same problem.
Exactly. Second, we'll look at the bronchodilators. We'll get into the chemistry of opening the airways, the beta agonists and the antimuscarinics, and we'll explore the history of why we had to redesign these drugs to stop them from stopping people's hearts.
A pretty important redesign. What's third?
Third is the controllers. This is the deep science. We'll be looking at corticosteroids and gene regulation. We're going to have to talk about histones and how DNA wraps and unwraps and why these drugs, they take time to work.
Okay, that sounds fascinating. And fourth?
Synergy. This is my favorite part of the pharmacology here, actually.
Right.
We'll explain why bronchodilators and steroids are essentially, they're molecular soulmates that actually make each other work better.
I love that, molecular soulmates. And what's our final stop?
Finally, we'll step into the present, into precision medicine. We'll see how we are moving away from this idea of sort of carpet bombing the lungs with drugs and moving towards sniper shots with biologics, specifically targeting what we call phenotypes.
Fantastic. That's a great roadmap. So let's start at the beginning, the battlefield. Asthma versus COPD. To a layperson or even someone early in their medical training, these can look very similar. The patient is short of breath, they're wheezing, they're coughing. But both CATSM and Goodman and Gilman are really adamant that these are distinct entities.
They are. And confusing them isn't just an academic error, it's a therapeutic error. So let's start with asthma. CATSM gives us a really solid clinical definition to build on. recurrent breathlessness and wheezing characterized by widespread reversible narrowing of the airways.
That word reversible seems to be doing a lot of heavy lifting there.
It is the absolute hallmark of the disease, at least in its early stages. It implies that the lung structure is mostly intact, but it's overreacting. It's spasming in response to some kind of trigger. It's a functional problem.
So it's a software problem, not a hardware problem initially.
That's a great way to put it. But to understand why it spasms, we have to look at the cells involved. Goodman and Gilman describes asthma as a kind of hair trigger inflammatory state.
So walk us through this cellular cast of characters. Who is actually starting this fight?
The primary villain, or maybe the misunderstood hero, depending on your perspective, is the mast cell.
Okay.
I want you to picture the mast cell as a kind of biological landmine that's buried just under the surface in the epithelial tissue of the airway. Yeah. And it is packed, just stuffed full of granules containing incredibly potent chemicals.
Okay, a landmine. So what sets it off? What's the trigger?
In classic allergic asthma, it's an allergen. So think pollen, dust mites, cat dander. The patient has these pre-existing antibodies, a specific type called IgE, that are specific to that allergen.
So their body has seen this before and flagged it as an enemy.
Precisely. These IgE antibodies attach themselves to the surface of the mast cell. They just sit there like little receptors waiting. So when the allergen floats in, say, you walk into a room where a cat has been, that cat dander binds to those antibodies. And specifically, it has to bridge two of them together. That cross-linking action is the physical trigger. That's the foot stepping on the mine.
Click.
Boom.
And the landmine goes off.
Exactly. The mast cell degranulates. It just dumps its entire payload into the surrounding tissue. And this payload is a cocktail of pure misery for the airways.
What's in it?
You've got preformed mediator, like histamine, and then you have newly synthesized ones, like the leukotrienes, specifically a type called cysteinoleukotrienes, like LTD4, which is 1,000 times more potent than histamine at causing bronchoconstriction.
1,000 times.
And you also get things like prostaglandin D2.
And what does this chemical cocktail actually do to the lung tissue?
It causes what we call the early reaction. This happens within minutes. The smooth muscle that wraps around the airways detects these chemicals and it just snaps shut. That's bronchoconstriction.
So the pipe gets narrower.
Right. And at the same time, the blood vessels become leaky, what we call microvascular leakage. So the walls of the airway start to swell up with fluid, you get edema. So now you have a narrow, boggy, swollen tube. That's the wheeze.
Okay, so that's the acute attack. You're wheezing, you're grabbing for your inhaler. But both texts talk about a late reaction. And this seems to be where the real sort of long-term damage starts to happen.
This is absolutely crucial to understand. The light reaction hits about 3 to 6 hours later. That mast cell didn't just cause a spasm, it also sent out a distress signal. It released chemotactic factors.
A call for backup.
A call for backup. These signals call in the heavy infantry from the blood. And in asthma, the heavy infantry are cells like eosinophils, Th2 lymphocytes, and a cell type called innate lymphoid cells type 2, or ILC2s.
And what distinguishes this second wave of cells from that first chemical blast?
The first wave was a spasm. This second wave is a siege. The Th2 cells and the ILC2s act as the battlefield commanders. They arrive and start releasing a new set of signaling molecules called cytokines. Specifically, we're talking about IL-4, IL-5, and IL-13.
Okay, and what do each of those do? They're not just random numbers, right?
No, they have very specific jobs. IL-4, for instance, tells B cells to switch over and make more of that IgE antibody. It perpetuates the cycle of allergy.
So it arms more landmines for the next time.
Perfectly put. IL-13 is a major driver of mucus production and some of the structural changes we'll talk about. And then there's IL-5. IL-5 is fascinating. It's essentially the survival signal for eosinophils. It tells the bone marrow to produce more of them, and it tells the eosinophils that are already in the lung to refuse to die. It extends their lifespan.
And eosinophils, they're not friendly cells, are they? They're pretty destructive.
They are incredibly toxic. They're designed to kill parasites. When they get into your airway, they release proteins with names like major basic protein and eosinophil caisonic protein. These aren't subtle signaling molecules. They're more like acids. They strip the epithelial lining off the airway. They damage the nerves. They cause profound tissue injury.
And if you let this happen over and over and over again, a kid has exacerbations every spring for 10 years.
You get remodeling. This is a term Katsung really emphasizes. The lung tries to repair itself from this constant eosinophilic damage, but it does a bad job. It heals with scar tissue.
What does that look like?
The basement membrane under the epithelium thickens. That's fibrosis. The smooth muscle layer gets bigger, a process of hypertrophy, and the cells multiply, hyperplasia. You get more and more goblet cells, the little factories that pump out mucus.
So eventually that reversible part of the definition starts to fade away.
Exactly. You have built a permanently narrower, twitchier, stiffer, mucus-filled pipe. The software problem has now created a hardware problem.
So that's the asthmatic profile. It's eosinophilic, it's allergic, it's Th2-driven, and it's prone to remodeling. Now let's contrast that with COPD. You called it the scarred lung in our prep notes, which is a powerful image.
It is a different beast entirely. COPD, chronic obstructive pulmonary disease, is usually not triggered by a specific allergen. It's triggered by chronic, relentless, toxic injury.
Cigarette smoke being the classic cause.
Cigarette smoke is the poster child, but long-term exposure to biomass fuel smoke, especially in developing countries, does it too. It's about particle load and oxidative stress over decades.
And the cellular response is different.
Completely different. In asthma, we saw eosinophils and those CD4-positive Th2 cells. In COPD, Goodman and Gilman tells us the dominant cells are neutrophils, macrophages, and a different kind of T cell, the cytotoxic CD8-positive T cell, also called a TC1 cell.
That sounds more like the kind of immune response you'd see for a bacterial infection or a dirty wound.
It is. It's a much more aggressive, less targeted kind of inflammation. And it attacks the lung architecture in two specific ways. First, it hits the small airways, causing what's called chronic obstructive bronchiolitis. They get fibrosed and plugged up with mucus and inflammatory cells.
Okay, so that's one part. What's the other?
The second part is the real tragedy of COPD. It destroys the parenchyma.
The alveoli themselves, the gas exchange surface.
Yes. The neutrophils, in particular, get activated and release powerful enzymes called proteases, things like neutrophil elastase, that literally chew up and dissolve the delicate walls of the air sacs. This is emphysema.
So the tennis court starts getting holes in it.
Big holes. Think of a healthy lung like a bundle of new, tight balloons. It has elastic recoil. When you exhale, it wants to spring back and push the air out. An emphysematous lung is like an old, floppy plastic grocery bag. The walls between the sacs are gone, the surface area is gone, and that critical elasticity is gone. Air gets trapped.
And unlike the smooth muscle spasm in asthma, you can't reverse destroyed tissue.
No. Once those alveolar walls are gone, they are gone forever. That is why COPD is a progressive and largely irreversible disease.
And you mentioned there's one more critical distinction that really sets up our whole pharmacology discussion.
Yes, and it's a huge one. Steroid resistance.
Okay, I want to put a big bookmark in that because that is a massive clinical problem. We will absolutely get to the mechanism of that resistance when we talk about the controllers.
Sounds good.
So we have the battlefield defined. Asthma is the twitchy, allergic lung. COPD is the scarred, destroyed lung. Now let's open the toolbox. Let's start with the drugs that provide immediate relief, the bronchodilators. And we have to start with the beta-2 agonists, albuterol, the blue puffer.
The most prescribed drug in all of respiratory medicine. And to understand it, we have to look at its target, the beta-2 adrenergic receptor. This is a classic G-protein-coupled receptor, a GPCR, that sits on the membrane of the airway smooth muscle cell.
Okay, so walk us through the signaling cascade. I take a puff of my albuterol inhaler. The drug molecule, the albuterol, lands on that receptor. What happens inside the cell?
So the drug binds, and the receptor changes its shape. This shape change activates its partner on the inside of the membrane, the GS protein. The S there stands for stimulatory.
Okay.
The activated GS protein then slides along the inside of the membrane and bumps into an enzyme called adenyl cyclase.
And adenyl cyclase is the factory.
It is. It's the factory for the second messenger. It takes ATP, the cell's energy currency, and it converts it into CANMP, which is cyclic AMP.
So CAMP is the signal that spreads through the cell.
It's the courier. And when the levels of CANMP get really high inside the cell, it activates another enzyme called protein kinase A, or PKA.
And PKA is the effector. It's the one that actually does the work.
PKA does all the heavy lifting. It goes around and phosphorylates several different targets inside the cell, but they all converge on one single goal: lower intracellular calcium.
Why is lowering calcium so important for relaxation?
Because smooth muscle contraction is entirely dependent on calcium. Calcium allows the two main muscle proteins, actin and myosin, to grab onto each other and pull. pKa messes this up. It activates pumps that push calcium out of the cell. It activates other pumps that hide calcium away in an internal storage compartment called the sarcoplasmic reticulum. It basically gets rid of all the free calcium.
No calcium, no grip.
No calcium, no grip. The muscle fibers simply cannot hold on to each other. They have to let go. The airway relaxes and opens up.
That's a really elegant pathway.
Yeah.
But historically, we had a major problem with specificity, right? Katzin tells a somewhat darker story about the evolution of these drugs.
Yes, the isoproterenol tragedy. In the 1940s and 50s, the best bronchodilator we had was a drug called isoproterenol, and it was a potent bronchodilator. It worked well, but it was completely non-selective. Meaning it hit beta-2 receptors in the lung, which is what we wanted, but it also hit beta-1 receptors just as hard.
If beta-1 receptors are in the heart?
They are all over the heart. Beta-1 stimulation is what drives up heart rate and the force of contraction. So patients would take their inhalers, they'd get relief from their asthma, but their heart rate would just skyrocket. Tachycardia.
And that led to problems.
It led to a disaster. In the 1960s, particularly in the UK, there was this unexplained, terrifying spike in asthma mortality. And it was eventually traced back to patients using high doses of these isoproterenol inhalers and triggering fatal cardiac arrhythmias. They were essentially inducing heart attacks to treat their lung disease.
That's horrifying. So that drove the chemists back to the drawing board to find a solution.
It absolutely did. It created a huge push for a safer drug. And they found one by modifying the original catecholamine molecule. They found that if you added a large, bulky chemical group to one part of the molecule, the nitrogen tail, it changed its shape. This new, bulky tail made the molecule fit perfectly, like a key in a lock, into the beta-2 receptor. But it was now too big and clunky to fit properly into the beta-1 receptor. That chemical tweak gave us albuterol, or salbutamol as it's known in Europe. It's highly selective for the lung.
But selective doesn't mean perfect, I assume.
No, it's a dose-dependent thing. If you take enough albuterol, you'll start to lose that selectivity and get some cardiac effects. Plus, we now know there are some beta-2 receptors in the atria of the heart, so you can get some direct stimulation there.
And what about the side effects like tremor, the shaky hands?
That's a direct beta-2 effect. Your skeletal muscle is full of beta-2 receptors. When you take albuterol, it stimulates those muscles directly. That's why patients get tremors. It's not because they're anxious. It is a direct pharmacological effect on the muscles in their arms and hands.
And you mentioned a metabolic effect as well.
Yes, and this is important in the hospital setting. Beta-2 stimulation activates the sodium-potassium pump on cells, which drives potassium into cells. So a patient who is using a lot of albuterol, say during a severe exacerbation, can actually develop hypokalemia, low blood potassium. And that, again, can predispose to arrhythmias.
Okay, so now we need to clarify the difference between a SABA and a LABA. SABA is short-acting, like albuterol. LABA is long-acting, like salmeterol or formoterol. Is the difference just a bigger dose, or is the chemistry fundamentally different?
It's all about the chemistry, specifically a property called lipophilicity.
Fat-loving.
Exactly. Albuterol is relatively hydrophilic. It likes water. It floats around, hits the receptor, does its job, and then it washes away pretty quickly. Its effect is gone in 4 to 6 hours.
And LOBA.
A LOBI, like salmeterol, is different. It has a massive, long lipophilic tail attached to it. It's like a tadpole with a really long tail. Katsuma explains that this tail allows the drug to anchor itself into the lipid cell membrane right next to the receptor.
Like it's putting down a little anchor.
Oh.
A tether.
It's precisely. It stays anchored in the membrane, and the active head of the molecule just keeps flapping over and hitting the receptor over and over again. Another theory is that the drug dissolves into the membrane, essentially creating a local reservoir, a depot, that slowly leaks the drug out over time. Either way, this gives you 12 or more hours of duration from a single dose.
Which sounds fantastic. I mean, why wouldn't we just give everyone a LABI and call it a day?
This brings us to the black box warning. And this is probably one of the most critical concepts in all of pulmonary pharmacology.
Okay.
LABAs are fantastic at opening the airway. They are great at masking the symptoms, but they do nothing for the underlying inflammation.
So they're a symptomatic treatment only.
Only. So if an asthmatic patient takes only a LABA, what happens? They feel great, they stop wheezing, they can run for the bus again. But underneath the surface, the eosinophils are still chewing up the tissue. The remodeling is accelerating. They have effectively turned off the smoke alarm while the fire is burning down the house.
And eventually that fire breaks through.
It does. And because the patient has been masking the problem for weeks or months, when the exacerbation finally happens, it's sudden and it's catastrophic. This led to an increase in asthma-related deaths in a major clinical trial called the SMART trial.
So the rule is what?
The rule is absolute. In asthma, you never ever use a labor alone. It must always be paired with a corticosteroid to treat the inflammation.
And what about in COPD?
Interestingly, in COPD, LABA monotherapy is considered safe and effective. It's one of the cornerstones of treatment because the underlying disease mechanism is different. The risk in asthma is masking that aggressive eosinophilic inflammation. In COPD, the inflammation is different, and the primary goal is maximizing bronchodilation to overcome the fixed obstruction.
That's a really important distinction. Okay, let's pivot to the other major class of bronchodilators. The antimuscarinics, sometimes called anticholinergics, drugs like ipratropium and the longer-acting tiotropium.
Right. So now we're leaving the sympathetic fight-or-flight nervous system, and we're moving over to the parasympathetic.
The rest and digest system.
Or in the lungs case, the constrict and secrete system. The main nerve of the parasympathetic system is the vagus nerve, and it releases the neurotransmitter acetylcholine.
And what does acetylcholine do in the airways?
Acetylcholine binds to muscarinic receptors on the airway smooth muscle, and the normal result of that binding is bronchoconstriction and an increase in mucus production. It operates via a totally different pathway, the GQ protein pathway.
GQ instead of Gs.
Right. GQ activates an enzyme called phospholyc C, or PLC. PLC generates a second messenger called IP3, and IP3's job is to go to that internal storage unit, the sarcoplasmic reticulum, and release all the calcium.
So it does the opposite of the beta agonists. It raises calcium.
Exactly. Acetylcholine is the body's natural way of keeping airway tone high, of keeping the pipes a little bit constricted.
So antimuscarinic drugs are just blockers.
They are simple competitive antagonists. They look enough like acetylcholine that they can fit into the muscarinic receptor chair, but they don't activate it. They just sit there and prevent the real acetylcholine from sitting down. No acetylcholine binding means no GQ activation, which means no constriction.
Now, Katzin makes a really interesting point that these drugs are often the first choice for bronchodilation in COPD, but they're more of a second or third choice in asthma. Why that preference?
It all comes down to a concept called vagal tone.
No.
In healthy people and in many people with mild asthma, the vagus nerve isn't particularly overactive. The background level of acetylcholine release is pretty low, so blocking it doesn't really add that much benefit on top of a beta agonist.
But it's different in COPD.
Yes. For reasons we don't fully understand, many patients with COPD have a high background vagal tone. That cholinergic drive is a major reversible component of their obstruction. So blocking it with a drug like tiotropium gives them a really significant release, a big improvement in airflow.
And what about the mucus?
That's the other part of the story. Remember chronic bronchitis? Many COPD patients have a huge problem with mucus overproduction. Antimuscarinics are great at drying up secretions. So for a COPD patient, it's often a two birds, one stone scenario. You get bronchodilation and you reduce mucus.
There's a little bit of nuance in the receptor subtypes here, M1, M2, and M3. And tiotropium is famous for being kinetically selective. What does that mean?
This is really cool pharmacology. So the M3 receptor is the one on the smooth muscle that actually causes the constriction. That's the one we want to block.
The bad guy.
The bad guy. But there's also an M2 receptor, and it sits on the nerve ending itself. It's an autoreceptor. It acts as a brake. It senses acetylcholine in the synapse and tells the nerve, okay, that's enough. Stop releasing so much.
So if we block M2?
We cut the brake lines, and the nerve just dumps out more acetylcholine, which then competes with our drug at the M3 receptor. It's counterproductive.
So what did the older drugs do?
Older drugs like ipratropium blocked M2 and M3 pretty much equally, so they were constantly fighting against themselves a little bit. But tiotropium, the drug in Spiriva, is really clever. Due to its chemical structure, it binds to the M3 receptor and stays stuck there for a very long time, over 24 hours. But it binds to the M2 receptor and bounces off very, very quickly.
So it's not truly selective, it's just about the timing.
Exactly. It's kinetically selective. It blocks the muscle constriction for a long time, but it leaves that crucial safety brake on the nerve intact. That's what makes it such a potent, long-acting drug.
Before we leave the bronchodilators, we have to, pour one out for the old guard. Theophylline.
Ah, theophylline, yes. Chemically, it's a methylxanthine. It's basically a cousin of caffeine. If you drank, I don't know, 20 cups of very strong coffee, you'd probably get some mild bronchodilation.
You'd also have a seizure, I imagine.
You'd also probably have a seizure, yes, but your lungs would be open.
So how does it actually work?
It's what we'd call a dirty drug. It has multiple, not fully understood mechanisms. The main one is that it inhibits an enzyme called phosphodiesterase, or PDE.
PDE, what does that do?
Remember how beta agonists work by increasing CAMP? Well, PDE is the enzyme that acts like a trash collector. It comes along and breaks down CAMP, turning the signal off. So if you inhibit the trash collector, CMP levels stay high and the airways stay relaxed.
And it has another mechanism.
Yes. It also blocks adenosine receptors. Adenosine is a signaling molecule in the lung that can cause bronchoconstriction, so blocking its effects is helpful.
But we don't really use it much anymore, do we?
No. The big problem is that it has what we call a narrow therapeutic index, meaning the dose that is required to help your lungs is frighteningly close to the dose that causes serious toxicity, nausea, vomiting, life-threatening arrhythmias, and seizures. Plus, its metabolism is all over the place. Smoking makes your liver chew it up faster, so you need a higher dose. A viral infection or certain antibiotics can make your liver chew it up slower, so your normal dose can suddenly become toxic. It's a nightmare to dose safely.
So its niche is where?
We mostly see it used now as a last resort, add-on therapy in very severe disease, or in low-resource settings because it is incredibly cheap.
Okay, that covers opening the tubes. Now we have to shift gears completely and talk about putting out the fire. The controllers, the corticosteroids.
Yeah.
If beta agonists are the sprint, steroids are the marathon.
That's a perfect analogy, and this is where we have to leave the cell surface and the rapid signaling pathways and go deep right into the nucleus. Beta agonists work in seconds because all the machinery is already there, waiting. Steroids take hours or even days to have their full effect because they are fundamentally changing the blueprint of the cell. They are gene regulators.
Okay, take us into the cell. Goodman and Gilman, chapter 40, describes this pathway beautifully.
So corticosteroids are lipophilic. They love fat. This means they can slide right through the cell membrane like a ghost walking through a wall. They don't need a receptor on the surface.
They'll just diffuse in.
They just diffuse in. Once they're inside the cytoplasm, they find their target, the glucocorticoid receptor, or GR. This receptor is normally just floating around, complexed with some chaperone proteins. The steroid binds to it, the chaperones fall off, and the drug receptor complex then moves into the nucleus.
And this is where the gene editing, so to speak, happens.
This is where it all happens. Now, the receptor can directly bind to DNA and turn on certain anti-inflammatory genes. But the most important mechanism in asthma is what we call transrepression. And to understand this, we need to talk about H8s and HDACs.
I love this part. It's such an elegant way to think about inflammation. So explain HE versus HDAC.
Okay. So your DNA is this incredibly long thread. To fit it inside the nucleus, it has to be wrapped around these protein spools called histones. When the DNA is wrapped really tightly around the histones, the genes in that section are hidden. The cellular machinery can't read them. They are effectively off.
Okay.
To turn an inflammatory gene on, like the gene for IL-5, for example, an enzyme called HAT, which stands for histone acetyltransferase, comes in. It sticks an acetyl group onto the histone tail. This causes the positive charge on the histone to be neutralized, and the negatively charged DNA uncoils. It loosens up. It opens the book so the gene can be read and transcribed.
So HAT equals DNA open, which equals inflammation on.
Exactly. Now, HDAC, which is histone deacetylase, does the exact opposite. It comes along and it snips off that acetyl group. The positive charge on the histone returns, the DNA snaps back tight, and the book closes. The gene is silenced.
So HDAC equals DNA closed, which equals inflammation OFF.
You got it.
So what do the steroids do? Which one do they work on?
This is the genius of it. The corticosteroid receptor complex goes into the nucleus and it grabs onto HDAC2. It physically recruits the off switch and drags it directly to those inflammatory genes that have been opened up by HAT. It forces the DNA to wind back up tight. It shuts down the production of cytokines, of KOX2, of adhesion molecules. It systematically silences the entire inflammatory program.
That is incredibly powerful. But it also explains why patients can get frustrated. They take their steroid inhaler during an acute asthma attack, and they feel absolutely nothing.
Right, because you can't feel gene transcription stopping. The effects are profound, but they are delayed. It takes time to stop producing new inflammatory proteins and for the existing ones to be cleared away. But without that steroid, the remodeling, the permanent damage just continues unchecked. The steroid is what saves the lung from destroying itself in the long run.
Now, earlier, you promised we would talk about synergy. We often treat moderate to severe asthma with a combination inhaler, a steroid, plus a LABA. You said this isn't just about convenience. It's not just saving shelf space.
No, it's true molecular teamwork. It's beautiful systems biology. Goodman and Gilman points out two amazing feedback loops here.
Okay, what's the first one?
First, steroids help beta agonists. If you use a beta agonist chronically by itself, the cell can become desensitized, it can downregulate the receptors, it stops making as many of them.
Tolerance.
Steroids prevent this. The steroid receptor complex goes to the nucleus and it actually binds to the gene promoter for the beta-2 receptor itself. It tells the cell, make more of these receptors. It literally puts more ears on the cell surface to listen for the beta agonist drug.
That's amazing. So it prevents tolerance. And what about the reverse?
Beta agonists help steroids. It turns out that through that CAMP-MP and PKA pathway we talked about, beta agonists can actually phosphorylate the steroid receptor. This makes it more efficient at moving into the nucleus. It's like the beta agonist holds the door open for the steroid to get to the DNA and do its job.
So 1 + 1 really does equal 3 here. They are fundamentally better together than the sum of their parts.
They absolutely are. It's a virtuous cycle.
That is beautiful, but now we have to drop the hammer. We have to come back to the problem of steroid resistance in COPD. We said earlier that steroids work great in eosinophilic asthma, but often fail miserably in neutrophilic COPD. Why?
This brings us right back to our friend HDAC2.
The off switch.
The off switch. In COPD, the primary insult is usually cigarette smoke, and smoke causes massive oxidative stress in the lung. This creates highly reactive molecules like reactive oxygen species and peroxynitrite. And it turns out that peroxynitrite directly attacks the HDAC2 enzyme. It modifies it through a process called nitration. It breaks it.
So the off switch for inflammation is physically broken.
It's physically broken and non-functional. So the steroid can get into the cell, it can bind its receptor, the complex can go into the nucleus, it looks around for HDAC2 to recruit to the inflammatory genes, but the HDAC2 is broken, it can't be recruited. The DNA stays uncoiled. The inflammatory genes keep getting transcribed. The inflammation rages on, completely insensitive to the steroid.
Which explains why giving high-dose steroids to a typical COPD patient often just gives them the systemic side effects, diabetes, osteoporosis, pneumonia, thin skin, without actually touching the underlying lung inflammation.
That is the molecular basis of steroid resistance in COPD.
Is there any way to fix that broken HDAC2?
It's a huge area of research. And interestingly, we mentioned theophylline earlier. There's some evidence that low-dose theophylline might be able to restore some HDAC activity. It's an area called steroid resensitization, trying to fix the switch so that our best anti-inflammatory drug can work again.
This leads us perfectly into our final frontier, precision medicine. For decades, we've treated asthma as if it were one single disease. Everyone got a blue puffer and a brown puffer. But Katsung and G&G both imply that this is a really outdated model.
It is. Asthma is a bucket diagnosis. It's a syndrome, not a single disease. We are now moving towards phenotyping. We're trying to classify patients not just by their symptoms, but by the actual biological driver of their disease.
And what are the big categories?
Broadly, we divide them into T2 high and T2 low asthma.
Define those for us.
T2 high is type 2 inflammation. This is the classic asthma we've been describing. It's driven by Th2 cells, by high levels of eosinophils, high IgE, and the cytokines IL-4, IL-5, and IL-13. These are the patients who respond beautifully to corticosteroids.
Okay, and T2 low?
T2 low, or sometimes called non-T2 asthma, is different. These patients have all the symptoms of asthma, the wheezing, the shortness of breath, but when you look at their sputum or blood, they don't have high eosinophils. Their inflammation might be driven by neutrophils, or they might have very few inflammatory cells at all, what we call posigranulocytic asthma. Their disease might be driven more by obesity or neural dysfunction or inherent defects in the smooth muscle itself.
And what is the critical clinical point here?
The critical point is that T2 low patients generally do not respond well to steroids. So for years, maybe decades, we have been giving these patients higher and higher doses of inhaled steroids, causing side effects, and wondering why they aren't getting better. And the reason is we were treating the wrong mechanism. We were using an anti-eosinophil drug in a patient who had no eosinophils.
So for the T2 high patients, the ones who are very severe and still not controlled on high-dose steroids, we now have the smart bombs, the biologics. These are monoclonal antibodies. Let's run through the big three mentioned in the texts.
Let's start with the first one, omalizumab, brand name Xolair. This drug is an antibody that targets IgE.
The antibody that arms the mast cell.
Exactly. Omalizumab floats around in the blood, and it binds to the free IgE before it can ever get to the mast cell. If the IgE is already bound up by the drug, it can't attach to the mast cell. It effectively disarms all those landmines.
Okay, what's the second major target?
The second target is IL-5. And there are several drugs here, like mepolizumab and reslizumab. These are anti-IL-5 antibodies. Remember, we said IL-5 is the food, the survival signal for eosinophils?
So you're starving them out.
You're starving them out. If you block IL-5, the eosinophils can't survive. They undergo apoptosis, programmed cell death. These drugs are incredibly effective and can reduce a patient's blood eosinophil count to essentially 0.
And the third one, which is making a lot of waves right now.
That would be dupilumab. This one is very clever. It doesn't target IL-4 or IL-13 directly. Instead, it blocks the IL-4 receptor alpha subunit. This is a shared component of the receptor for both IL-4 and IL-13.
So you get a 2-for-1.
You get a very powerful 2-for-1. By blocking one receptor component, you shut down 2 of the major T2 pathways. You stop the IgE production that's driven by IL-4, and you stop the mucus production and remodeling driven by IL-13. It's a very potent drug for severe eosinophilic disease.
But these are not cheap drugs.
Not at all. They are extremely expensive, which is why you have to get the phenotype right before you prescribe them. You have to do the workup. You measure the patient's blood eosinophil count, maybe their exhaled nitric oxide, which is a marker for T2 inflammation. If you give an anti-eosinophil drug like mepolizumab to a T2 low patient who has no eosinophils, you are just burning tens of thousands of dollars and helping absolutely no one.
Is there anything new on the horizon for COPD? Or are they being left out of this biologics revolution?
For the most part, they are being left out because the inflammatory pathway is much messier and harder to target with a single smart bomb. But there is one newer drug for a specific subset of COPD called roflumilast.
Yep.
This is a PDE4 inhibitor. It's like a highly specific scalpel version of theophylline. It specifically targets the type 4 phosphodiesterase that's found in inflammatory cells like neutrophils. And in patients with severe COPD who have a chronic bronchitis phenotype and frequent exacerbations, it can help reduce those exacerbations.
Well, there's a catch.
There is a big catch. It has significant gastrointestinal side effects. Diarrhea, nausea, and weight loss are very common. It's not a fun drug to be on, but for the right patient who is having frequent hospitalizations, it can be a lifesaver.
We've covered the molecules in incredible detail. Let's bring it back to the clinic for our final segment. Drug delivery and strategy. It seems obvious, but why do we use inhalers? Why not just give everyone a pill?
It's all about minimizing toxicity. We want to achieve very high concentrations of the drug in the airway where we need it, and very low concentrations in the rest of the body where it just causes side effects. But getting the inhalation physics right is tricky. Particle size is everything.
And Katsung gives us a Goldilocks zone for that, right?
It does. The ideal particle size is between 2 and 5 microns.
Why that specific range? What happens if it's too big or too small?
If the particle is too large, say greater than 10 microns, it has too much momentum when you inhale it. You can't make the turn at the back of the throat, so it just slams into your oropharynx and sticks there. You end up swallowing most of the dose. It becomes an expensive stomach pill that gives you systemic side effects.
Like getting oral thrush from an inhaled steroid?
That's the classic example. And if the particle is too small, say less than 1 micron, it's too light. It behaves more like a gas. You breathe it all the way down into the alveoli, it bounces around, and then you just breathe it right back out. It never has a chance to settle where it's needed in the bronchioles. The 2 to 5 micron range allows it to ride the airstream down to the medium-sized airways and then settle out by gravity, a process called sedimentation.
And finally, let's talk about the stepwise approach to management. We don't just throw the kitchen sink at a newly diagnosed patient on day one.
No, absolutely not. We escalate therapy based on how well the patient's symptoms and risks are controlled. Step 1 is just a SABA, an albuterol inhaler, to be used as needed for symptoms.
Okay.
Step 2 is the big jump. And current guidelines say if a patient is using their albuterol more than twice a week, that means they have persistent inflammation and they need a controller. So we add a low-dose inhaled corticosteroid. That is the cornerstone of asthma therapy.
Yeah, if that's not enough.
Step 3 is usually to either increase the dose of the steroid or, more commonly now, add a LABA to get that synergy we talked about. And then steps 4 and 5 are for severe disease where you're using high-dose steroid-LABA combinations, maybe adding a long-acting antimuscarinic or LAMA, and then finally considering these expensive biologics for the right phenotype.
Okay, I have 2 check-in questions for our listeners just to see if they've been paying attention and can apply some of this.
Let's hear them.
Question 1. A patient tells you, I use my blue albuterol inhaler every single day, and it works great. I feel better right away, so my asthma must be fine. What is your assessment of that situation?
That is a 5-alarm fire. That is a huge red alert.
Yeah.
The albuterol's working. Yes, it's treating the spasm, the symptom, but the fact that they need it every single day tells you that the underlying inflammation, the pathology, is completely uncontrolled. They're just masking the fire. That patient is at extremely high risk for a severe, potentially life-threatening exacerbation. They need a controller, an inhaled steroid, immediately.
Perfect. Question 2. Why do we often use a drug like epratropium, an antimuscarinic, as a first-line bronchodilator in COPD, but almost never for mild asthma?
Because the underlying pathophysiology is different. Mild asthma is primarily an allergic inflammatory disease, so it's best treated by targeting that inflammation with steroids and the resulting bronchospasm with beta agonists. COPD, on the other hand, has a significant component of fixed structural narrowing, but it also often has that high background vagal tone, that cholinergic drive. Blocking that vagal tone gives COPD patients a significant amount of bronchodilation that many asthmatics simply wouldn't feel because their vagal tone isn't as high to begin with.
Fantastic. Let's wrap this up with a synthesis. We've covered a huge amount of ground today, from the cell surface to the nucleus.
We really have. We established that the lung is this vulnerable active interface. We learned that asthma is typically an eosinophilic Th2-driven fire that leads to permanent remodeling if it's left untreated.
And COPD.
And we learned that COPD is a neutrophilic destructive process that is tragically resistant to our best anti-inflammatory drugs because of HDAC2 failure.
We saw how beta agonists use the CAMP pathway to rapidly open the door, but carry the risk of masking the underlying inflammation if used alone in asthma.
And we saw how corticosteroids don't just put out the fire, they work by recruiting genetic silencers, these HDACs, right to the DNA, taking time to basically renovate the house from the inside out.
And finally, we saw how biologics are the new generation of precision tools that allow us to move beyond a one-size-fits-all approach and target the specific phenotype driving a patient's disease.
It's a huge step forward.
I want to leave you, our listeners, with a provocative thought that comes from Katsu. The text mentions that some studies suggest that up to 50% of mild to moderate asthmatics might actually be T2 low.
It is a staggering statistic when you first hear it.
It really is.
Yeah.
Because if that's true, and our primary controller drug, the inhaled corticosteroid, works almost exclusively on T2 high inflammation, are we effectively treating half of our asthma population with a drug that barely works for them?
That is the multi-billion-dollar question in respiratory medicine right now. It suggests that for decades, we've been lumping patients together under this one umbrella of asthma. The future of this field isn't just about finding stronger drugs. It's about getting better at diagnosis. We need to stop treating asthma and start treating eosinophilic airway disease versus neutrophilic airway disease versus neural airway dysfunction. The names will change. The entire paradigm is going to change.
A sobering but also very exciting thought. We're really just scratching the surface. Listeners, your mission is clear. Open up Kitsung Chapter 20. Look at the clinical charts, especially the one on the stepwise approach. Then, open Goodman and Gilman Chapter 40. Look at Figure 40, then hold my schematic of all the cellular mechanisms. That diagram of the mast cell degranulating is worth 1,000 words. Don't just trust our summary. Go see the evidence for yourself.
This deep dive was your map. Now go explore the territory.
Thanks for listening. We'll see you on the next deep dive.
Breathe easy.